Hi, and welcome. A warm welcome to Think Differently by Design listening tour with your hosts, Dina Redinger and Sharon Weinstein, co-authors of the book, Think Differently, 18 Strategies to Fix Broken Thinking. We invite you to engage with your peers and us as we address issues related to nurses, nursing, and of course, the workforce. In our studies of those in leadership positions, we have found that success happens when we ask the right questions and solve the right problems. We invite you to consider being a part of our program. So reach out to me if you're interested and we'll schedule you for a session. We conduct these live interviews on Tuesday and Thursday through the first quarter of the year. And our goal is to provide nurse leaders with the opportunity to be heard, to express their opinions, to share ideas, and to tell their stories. But before we begin, I want to acknowledge you and thank you for joining us today. We have viewers from across the globe. Please use the chat and let us know where you're from. Today, we welcome a longtime friend and special guest, Dr. Nancy Valentine, interim chair of the School of Nursing at Northern Illinois University. Her career includes experience in administrative roles in government, military, city hospitals, academic health centers, community hospitals, and university-based schools of nursing. She has held roles as chief nurse at 3 academic health centers, senior vice president for Cigna Healthcare, and national chief nursing executive for the U.S. Department of Veterans Affairs, leading 65,000 members of a nursing team in 173 medical centers across the country. A fellow of the Academy of Nursing, the National Academy of Practice, and a founding board member of the American Psychiatric Nurses Association, Nancy is president of Valentine Health Group, LLC, a consulting group focused on leadership development, organizational strategy, workforce development, and quality outcomes. Welcome, Nancy.
Well, thank you, Sharon, and thank you, Dina. Sharon, as you said, we're old friends, and Dina, I've had the pleasure of getting to know you through this engagement. And I first want to thank you for adding me to your leadership circle to really have these conversations, because I think that this kind of thought leadership is really hard to come by. Most of the time you have to bump into your friends and colleagues or go to meetings and sort of hang out with people that are, cutting edge, et cetera. But to have this, portable where people can listen to it at their own time, speed, and whatever interest is really very nice. So I applaud you for putting this together. Thank you.
You're so welcome. And if you're out there and you've joined us, we want to know where you're from. Certainly join us in the chat. Put your comments in here. We'd love to hear from you as we start to find out more about, Nancy's thoughts and ideas. And so we're going to start off with a question, if I may. We'll get rolling here.
Sure.
All right. So why does the concept of health get lost in the translation when it's linked to this concept of care? As people are paying more and often believe they're getting less.
Right. It's a very complicated equation. And I think that before you can address what are the strategies to fix it, you have to have some appreciation for why it is so complicated. Steve Forbes, the editor-in-chief of Forbes magazine, the business roundtable, of all the periodicals, commented at the last presidential election that he couldn't believe that the candidates were not discussing healthcare because it's 20% of our economy and it's exceedingly personal. Well, you can see, down the road when other people tried to take on how to fix healthcare, the big giants, Microsoft, not Microsoft, but Google and some of the heavy hitters, they backed away after a couple of years because it's a daunting undertaking. And I think what we've seen through this pandemic, Dina, is that there's so many different expectations of the population in terms of what is health and what is health care. I don't think that we ever really had a full appreciation for that, but it certainly came out in vivid living color about how what healthcare is to one person is considered, poisonous to another.
Right.
So I'd like to, though, think about how to trim it down, because we don't want to get bogged down in all the problems. But some of the background really does help us to understand and have a context for why we are really challenged to think about how we as an individual or as a small team on a unit, or if you're in public health or you're in a hospital, wherever you are, what can you do to make a difference, to put the health back in healthcare and not be, just pounded down by all the problems and the negativity. I think that where we really start is the business model. The business, everything's a business. I mean, we're in the United States of America. So everything is around, payment, revenue streams, as one person said, if you're caring at home, most of the care done at home is done by the women family members. I can attest to that. We're doing that with my mother, and you do it for free, or it changes your career as it did for me. You can't be working, high powered full time and taking care of a distressed family member. But when care is actually inside an organization, it's a business. So it suddenly takes on a whole other venue. So the whole idea of how it is financed is really an issue for us, especially in this country, because it is so episodic, it is so piecemeal that the way it's paid for then drives how the care is delivered. So, for example, some of the things that we do in the United States with healthcare are just spectacular. We have a lot of technology. We have some extremely talented people, doctors, nurses, others, who really are change agents and have really, changed how healthcare is delivered. On the other hand, we have huge public health problems, population health for particularly women of color who postpartum issues are enormous. Infant mortality is dreadful. It is like the worst of many nations on this planet. We really rank very, very low in those things. We know what to do. And nurses are primary actors in that equation, but nobody's paying for it. So other countries where they do postpartum visits for a year or in a distress situation, even longer, they have really good outcomes, but we don't. We are, very into the payment for NICUs and very intensive care up front. And then we sort of everybody falls off the map once they're discharged. There's the cliff and they're falling off of it. So that is a huge problem from a policy perspective until we really take a look at that in a very big picture way. We're going to be stuck with what we have right now. The other end of that, Dina and Sharon, is, how we deliver care in hospitals, for instance. We are caring for people that have really no hope of recovery. And we don't put people in hospice early enough. We don't have those conversations. And honestly, it's not always the family. It's a lot of the physicians who don't really want to move that person into hospice. I mean, one could say, is it that because they just want to keep billing, because more days in the intensive care unit is revenue producing? Or is it that they just feel that they have to try everything because their training has been geared to heroic measures? It's really hard to say. It could vary, person by person and situation by situation. But I think that the public needs to really put more pressure on determining some of these things, because we're paying for those kinds of interventions, and we're not paying for those interventions, like I just mentioned, that are really more public health oriented for, populations that could really benefit from some of those.
If I might, you mentioned this whole concept of not providing the kind of care that we need postpartum and whatnot.
Right.
I think, Nancy, that it's very interesting to note that in some countries in which I've worked, when a nurse goes on maternity leave, their job is held for 2 years at full pay.
Oh, that's
until
incredible.
They return.
That's pretty.
That
that's
makes
remarkable.
for a very positive work environment in which people want to be engaged.
Absolutely.
They want to work for that organization. They want to be there.
Right.
So I think sometimes we just address it the wrong way. But given the complexity and so many of these competing variables, what can we do to refocus on health? I know you've said there are 3 C's. What are they?
Well, I think one is, the business of healthcare, and a lot of it, I think, could happen from inside an organization. I've as you mentioned, I've worked across many dimensions of healthcare, but the ones that are really the heavy hitters are the inpatient acute care hospitals and healthcare systems. That's where, if you make some of these changes, you could, have revenue consequences. So instead of bringing expensive consultants in that do the metrics and figure out which product lines are working, which product lines are losing money, I think hospitals leadership has to take some of that responsibility and see what they can do to fuel some of the directions and the strategies going forward, and not just keep going along with, business as usual.
Mm-hmm.
I think the other strategy that I really wanted to bring up today is leadership at every level. I have to say that in my career, I have worked for some really gifted leaders, and they weren't all clinicians. Some of the people that I worked with in VA at top levels, they were legal, they were lawyers by background, or they had had a lot of grassroots work, community development work. They knew how to lead people, and they knew how to lead change, and they knew how to take on some pretty daunting problems, which you can imagine in VA, which are highly publicized. They knew how to do it. But a lot of leaders are really not that talented. I mean, that's been my experience. They are very good at getting their positions, keeping their positions, and not necessarily driving change, and really bringing the thought leadership like we're doing today. What are the alternatives? What can we do differently? They are really just trying to keep the ship afloat and keep moving forward. It is a hard job. I'm not minimizing the challenges, but I don't see a lot of people raising the ideas of, what do we need to do to make this different? And then I think the other factor is there's like a lot of other businesses. One of the things, like if you're looking at less complex businesses, you have to run the business the same no matter where you are. I mean, you can't have a lot of variation, but healthcare is like the poster child of variation. You've got variation everywhere you look. You have top hospitals that are getting spectacular outcomes. They are applauded. You read about them. They are to be admired. I mean, it's hard work. Then you see a lot of hospitals that get dreadful outcomes, and there are no consequences. You don't hear about hospitals closing because they had bad outcomes, and therefore, they're not in business anymore. What they do is they get bought, they get sold, they change their name, whatever they do to sort of mask some of those underlying issues, which again are always, somewhat financially driven. It's really, really hard to get that standardization. And I'm not talking about cookbook medicine or cookbook nursing, but there are standards. And I think what a lot of consumers, depending on their level of sophistication, don't realize how you really have to shop around for providers. A doctor is not a doctor. If you have a special condition, you need to find like the best person that can treat you. And it may not be at your local community hospital, or it may be at your local community hospital. You shouldn't rule out anybody until you've checked them out. And that's a very daunting task for the average consumer. So I think those three things: it's the business, it's the leadership or lack thereof, and it's so much variation, and that we have learned to live with it. So there are over 5,000 hospitals in this country, and it's really only the tippy top that are really outstanding. I don't know what that percentage would be. What you could talk about. What would be the criteria for that? But not every hospital is really a place that you want to be treated in.
Right.
Yeah. I've got a couple things. I was kind of a take home, and I want to go to this person who commented because it's an important comment. But one of the things that you said that really struck me, is that, let's be honest, it's personal. Healthcare is very personal.
Very personal.
And that leadership, it's really not coming from the top down anymore, because it's kind of the old antiquated way of leading. We really need to find out from the bottom up approach. Otherwise, we're going to miss some of that personalization and making a difference, is what I'm thinking.
Right. But Dina, that takes a mindset of
It
being
does.
a transformational, inclusive leader.
Yes.
There are people out there, believe me, I've met them. They think they're doing it, but they're not.
But they're not.
And that's even worse, because you got to explain to them that this is not happening.
Right. Yep.
And it's painful.
It is painful.
For people. And I think this is where nurses and physicians and frontline people come in. I think we need to sort of turn the tables, and I'd like to see more feisty people out there. People that are coming to the table to discuss these things. If the top leadership isn't discussing it, then the people that are actually delivering the services need to bring it up. Now, case in point, the nurses in New York that were striking about a week ago and then just settled. It's so amazing. I mean, they did a wonderful article, in the New York Times just a few days ago. And they pointed out that the nurses were not asking for a raise. I mean, they got a raise, which was good, but their main thing was quality outcomes. And they are in good hospitals, but they are saying that the outcomes are really driven by the nursing workforce. I mean, nurses are the main players in a lot of these outcomes, not necessarily the surgical outcomes, although, surgical infections, everybody's, involved with that. But a lot of these nurse sensitive outcomes are driven by your nurse staffing patterns. So their number one is they want to be excellent. They know what they need and they're not getting it. Now, does that mean only more nurses, or does it mean how we deploy the nurses? What is the way we are going to do nursing in the future? Like one colleague said to me at dinner the other night, she said, we can't do she's a nurse. We can't do nursing the same old way because we've just invested in so much technology at the bedside and in between, and we have to get a trade-off. But I pointed out to her, I said, that's the rub. So much of this technology requires nursing care. You have to monitor things. You have to check on them. Yeah. Some of the charting in some of these medical records it's not easy. There's a lot of redundancy in
technology doesn't replace hands-on care.
It doesn't. So there's another, big fat, dollar sign on, if you're at the top or you're a board member saying like, why does it cost so much? We just put like $10 million into whatever. Sorry, I forgot to put this on mute after we talked earlier. Anyway, I think that it's a really, really complicated problem. And as I see, we have a listener from Houston saying, do revenue consequences mean poor outcomes? Well, they are tied together for reasons I just mentioned. Your staffing patterns are critical. And that's why nurses are pushing in 3 states right now. I think it's Boston and Washington and maybe Seattle. I don't want to be quoted on that, but they're pushing for standardized staffing patterns because, again, there's so much variation. The good hospitals that I was affiliated with, I felt very, fortunate to be so. For the most part, we were able to get the resources that we needed in order to do the job. But everybody's always looking to cut costs. Right. And that's the name of the game.
Right. And you can't cut cost if it means that you're going to cut your outcome.
They are tied together. Now, that doesn't mean that training people and making sure they're really on their toes about how to monitor their practice so that they do get good outcomes. That's all part of a good hospital system, really keeping people on track and on target. And the other is, we have to really work in teams. There's so much we could talk about. I know we don't have near enough time, but let's keep going because people that are listening to this program are the key to the future. You are each a key. You can do something in your area. But look at where we're at right now. It is absolutely worst case scenario. Post-COVID, most hospitals are looking at enormous losses in the hundreds of millions of dollars in some cases. You cannot cut your way out of that kind of loss. And yes, the nurses contributed to it by everybody rushing off and going into these travel nurse arrangements. I mean, they were getting these incredible bills. But that's not the only solution either. But if we look at what is happening in the nursing workforce, it is like the canary in the coal mine. All these people leaving and like running away and finding other alternatives. We have to pay attention to that. My consulting work, that's what I really want to focus in on. How are we going to capture how are we going to recapture some of the people that have left? How are we going to grow and sustain our workforce? If we can't do that, we really are in deep trouble.
Yeah.
We can't keep growing new people.
Right.
No.
And throwing them in. I mean, the last 2 years for anyone that graduated, they had like no clinical experience. They couldn't
Right.
get inside of a hospital. So their ramp up time is going to be longer for, really being able to comprehend, again, the complexity of really what's going on in the workplace. So I give them a lot of credit for like sticking with it until they really get that down. The other is we have to change our educational system. And that's really hard. If you think it's hard to change practice and leadership inside of the delivery system, I think it's more daunting to do it inside the educational system. Nursing education is wonderful. There are so many talented people. They're doing research projects, all kinds of interesting things. On the other hand, it's still a very isolated world. And I think nurse educators and nurse leaders need to reach out. They need to have more partnership with people in medicine. I mean, organized partnership, not like, hello, let's get along, that they really organize programs, public health schools, and if you're in a smaller community-based hospital, you're not affiliated with a medical center or a university, that you find other players in your community that really are part of building an infrastructure of collaboration. So when you look at the curriculums, the need for developing self-care approaches are incredible. Just think of the faculty. I mean, look at the faculty. I mean, nice people, but like all of us, we need to exercise more. We better like pay attention to our nutrition. The whole mind body balance. Let's start with the faculty. And I think there are some schools like The Ohio State, Bernadette Melnick. She is a total, change agent in that field. But we need everybody to think about that.
Yep.
And the other thing in the curriculum that's like really lacking is teamwork. We don't train people on how to work in teams. They are just then let loose when they graduate into these complex work environments, and they're supposed to know how to be a team player. It's again, it's practice, practice, practice. And I don't know that those things are being highlighted in the curriculum. So we have to really take a look at that as another area of opportunity.
Yeah, I'm gonna say one point. I'm gonna go back to Sharon, but one of the things that I think is really important, and you brought it up, is that if you are out there and you're in healthcare and you're nursing, ask to get to the table, share your ideas for change, be relentless, be confident,
right,
and try to figure out how to get there. Because unless we have sharing of the ideas, people want to just throw up their hands and say it really just doesn't matter. You're not going to listen. So we need to invite those people, those women, those nurses, and men and women to the table, to the leadership table.
We do.
Well, as I think that's a good first step, but again, dig deeper. It's not just getting to the table, it's having a voice and being appreciated for your ideas, not dismissed.
Absolutely. Right. Thank you.
It's much more than lip service. You're exactly right. It's having a voice, it's having a seat and having a voice. We've both spoken about that, Dina and I. And what good is having a seat if you don't have a voice?
Right.
And if you don't have a seat, bring your own chair. And if you don't have a voice, just use what you've got.
Right.
Nancy, we could go on forever and ever and ever. I do have one question because we are going to run out of time, and this is so important. How would you summarize the discussion? What 3 key points would you give our listeners? What would you give them as takeaways to consider as they move forward? Right.
Well, I think because of the pandemic, I think this whole idea of caring for yourself, it's so important. You don't have to have been in an ICU where you were just slammed and now you're like having PTSD. I mean, that's a whole cohort of people that probably need really deep treatment.
Right.
I mean, at VA, they did a great job, because after they diagnosed people with PTSD, they actually treated them. What do? We just call them up and ask them if they can do another shift. So we have no intervention.
That's the truth. Yeah.
Scoped out for that group, but you don't have to be one of the people that were really in that tank. You can be anywhere, but you have to start thinking about how am I caring for myself? Nurses don't do that. And then they wonder why they're tired, why they're aging more rapidly, all the rest of it. So I think that's really, in my book, anybody that's listening really can do a better job of that. And believe me, we need a lot of prompts. I mean, I'm in a research study on how to get people to exercise more. And believe me, it made a difference. I have all kinds of prompts. I'm now wearing, a Fitbit. I mean, I wouldn't have dreamed of doing that unless I was in the research study. So I think that, we all can improve. I think the second thing is to stop thinking in hierarchical terms. Like you're a staff nurse. Okay. I'm like low woman or man on the totem pole. Like what can I?
Or just a nurse, as they say, right?
Yeah. And that's getting old. After you spent money to, all this money and you're paying off your school loans, you're not just a nurse, you're a full-fledged graduate with debt and you're working, you need a voice and you need to, let your ideas be known. So stop thinking small, think larger. And then I think the last is to look around with, you have employment opportunities. And since not every organization is the same, be picky about where you work. Go look for the places that are magnet designated, or look for places that have good outcomes. Look for places that people want to work at, because I think that's what I'm going to try to do in my practice, is get leaders to recognize that maybe one of the reasons they're not getting more nurses is because their environment is not a caring
conducive.
environment.
Yeah, absolutely. Yep.
And they have to to put health back in healthcare. You have to think about that in the terms of like, is our organization healthy? What are we doing to promote health and wellness?
And we don't mean health from the bottom line. We mean the entire environment in which people are called to work.
And here's an example. I mean, there's a beautiful, beautiful hospital. I won't say which one, because there are many beautiful hospitals in Chicago. And I operate out of both Philadelphia and Chicago. And I actually was getting some treatment at this place. And I walked in, and for the first time, and I could not believe it. I mean, this place looks like a bank. Marble, it's beautiful, beautiful. Banks in the old days, I'm thinking, not like today's bank where you just drive through. But the real, elegant banks. But it was so devoid of any humanism. There was no artwork. There was no music. And I thought, if I was running this place, I would have community art shows regular. I'd have like little orchestras in the lobby on Fridays, something that really brings the community into this magnificent location and really jazzes it up a little bit and makes it like a place you really want to come to, other than just having your medical appointment. So I think that there's so much opportunity. You have to be a creative thinker. You have to be an out-of-the-box thinker. There's not one person listening to this show that couldn't come up with 10 intervention strategies of their own and really make a list and start checking it off as you try it out. I mean, it will work. Maybe not everything will, but try it. Don't be shy and don't be reticent. Try new approaches. You can do it no matter what your job title is. And I wish them all the best, because it's people that are going to put the health back in health.
Exactly. It is the people. I'm smiling because I lived in Chicago for 30 years and I know the facility you're talking about. And I've often had the same impression. What a magnificent hotel. Right. What a magnificent something. There's no life to it. There's no warmth. There's nothing that makes you want to come in and come back.
And it would be so easy to do, low cost.
Yep. Exactly.
Yeah.
Exactly. Go ahead, Dina.
No, I just wanted to say thank you, for your brilliant ideas and sharing some of these great strategies. I want to thank you for being on today with us, and I'll have you close us out, Sharon.
Okay. That was really great, Nancy. So much more interest than I ever imagined. What's going to happen is we're going to get 10 or more questions after we close the broadcast. But that's not a problem, because we'll respond to those as well.
Okay.
What we do want to do is make sure that people know about the retreat, the executive nursing retreat that Dina and I are hosting in Branson, Missouri from November 1st to the 4th. If you're interested, if you're a leader who's wondering, A, how to put that healthcare back in, and B, how to deal with workforce issues, this is the place for you to be. But for now, it's time for a close and an invitation to join us again as we welcome yet another one of your peers to the program. Again, if you would like to participate, please reach out to us. We're
Yes.
always eager to hear from those folks who are out in the field, out on the front, doing what needs to be done
That's right.
to ensure that healthcare does, in fact, mean quality and that they resonate. Thanks
Right.
for being with us today.
Yes. Excellent.